right, welcome everybody. Hello to our new people that are joining for the first time today. My name is Stephanie. I am a fourth-year medical student at the University of Iowa, Carver College of Medicine in Iowa, the Midwest. So I'm calling in tonight to give a talk on lymphomas. So this is virtual rounds, and we do like a case-based learning session. So I'll give you a little information about what the patient is presenting with, and then we'll get more information as we go along. And you guys are, welcome, encouraged to participate and think critically about, the next step in this patient's workup and eventually in their care. So we'll start with, next slide. So this is actually like a pediatric patient that we're seeing, or an adolescent. So I just put this little meme in there. When I was on my peds rotation, this definitely was true. A lot of the babies just really hate when you look in their ears, and I don't blame them, especially when you have a med student looking in your ears who might not know what they're doing or has only done it, a couple times. Okay. So yeah, like I said, we'll go through this case and we'll learn a little bit about the patient and we'll get more information as we go. You guys are definitely encouraged to actively participate, and you should have access to this SOAP note if you want to fill it out throughout the presentation to kind of come back to, or just to take notes, that sort of thing. And then at the end, there's going to be a quiz, as always, that is offered for you to get 80%, you get a certificate, and you can take it again, if you don't reach your goal the first time. Okay, so if people want to mark where they're from or just drop it in the chat, that would be, that might be easier too. It's always nice to see where everybody's calling in from. Okay, welcome, awesome. Okay, great. Great. Maybe we should expand our map a little bit, get some places outside of the immediate US. Okay, awesome. Well, thank you all for coming in, for joining in. Let's see here. What do I do? Oh, you guys are knowing how to remove it. Great, awesome. All right, so let's get started with, somebody said, from China. Okay, great. Yeah, that's wonderful. Thanks for joining in. What time is it in China right now?
It's currently 10 a.m. on Friday.
Okay, wow, interesting. Great. And then Houston, Texas. Okay, cool. Well, I'm glad that we have everyone here. Los Angeles, great. I've only been to San Francisco in California, but I want to go back and try. I'm looking in California for residency perhaps. And so I'm excited to maybe explore the area, have some warmer weather. All right, so we will go ahead and get started with this case. I'll just read this first paragraph here and have you guys can get to thinking about this. So we have a 15-year-old boy named Noah who presents to our clinic. It's an outpatient clinic for a painless lump on the right side of his neck. He comes in with his mother, Tanya, and he says that the lump has been present for about 5 weeks now. So they decided to come to the office today because they think that the mass or the lump may have grown in size. Okay. Sorry, for some reason, this won't let me choose the eraser. Okay, so some questions to consider. And you guys can think about this for a bit, and then you can either unmute yourself or put in the chat any thoughts that you might have. So what is the differential diagnosis, or what are the possible, medical conditions that cause a neck mass in a pediatric patient? And I will say I put solid here with a little asterisk because neck masses can be caused by like developmental things or developmental abnormalities. Those are often like cystic. Sometimes we talk about like having what's called a thyroglossal duct cyst in a pediatric patient. It kind of looks like your like bulge in the middle of your neck around the thyroid, and that's due to the duct not closing properly. But for just, for today's sake, or for tonight's session's sake, we're just going to be talking about the other causes, not the developmental causes. So not the cystic causes of neck masses, but solid neck masses. What can cause a solid neck mass, or what do you think could a solid neck mass be in a patient that is coming in with this concern? A tumor, great. Yeah, thanks for saying that. So some sort of malignancy, right? An infection. Awesome. Yes, definitely an infection, right? We've all been probably sick before with, either the flu, some sort of bacterial infection. Maybe you've had COVID before and you get those swollen lymph nodes. And so definitely you could have an infection. Someone says thyroid issue. Absolutely, right? So maybe that's any sort of issue with the thyroid. We've talked about, I believe, like hyperthyroidism before. I think I did a session on that. And so even those causes of hyperthyroidism, like Graves' disease, can present with like that goiter, that big neck that can kind of look like a lump. So yeah, Adam also saying immune system. Yep. So immune system is functioning as well. So like an autoimmune disorder. Great. So the immune system, right? I kind of alluded to this when I said lymph nodes. And maybe I'm giving you the answer right now, but the immune system, what sort of system in our body plays a big role in the immune system? Thinking along the lines of, is it blood vessels, just tissue? What are they called? Red blood cells are important. Absolutely. Lymphatic system, great. Yeah, that's kind of what I was getting at too. The lymphatic system, right? So the lymphatic system is really important for immunity and for, oh, it's okay if you guys misspell the words. I'm not a good speller either. So but anyway, so yeah, the lymphatic system is really important for delivering certain cells to areas of our body that are trying to fight infections, right? And so somebody had mentioned that a possible differential diagnosis for a neck mass would be infection. And you can imagine if you had some sort of virus that in your lymphatic system, some of those B cells and T cells, I don't know if you guys have heard about those before, but they're cells that help us fight off infections. They'll be migrating to those areas where the infection is, and then you'll get a swollen lymph node. Okay. So great, you guys already came up with a lot of good ideas. So one is infectious, as I had just mentioned. So some of those causes are common colds, group A strep. Have you guys heard of group A strep or strep throat at all? Yeah, great. Yeah, sometimes, it's often seen like the white patches on the back of the tongue that can be indicative of potentially strep throat. Kind of people come in and say like, oh, it's like a razor burn when I swallow. And then there's some other things as well. One thing to look out for when you have an infectious cause of a neck mass is you need to be careful that something really serious isn't going on, like maybe an abscess in the throat. So certain bacterial infections can cause like abscesses or big pockets of like pus in the tonsils, and that can compromise the airway. So it's really important to assess the patient and see, is this an emergency? Are they breathing okay? Do all of that first and make sure that it's fine to then perform a thorough exam, because you don't want to miss something when they're, in some sort of emergent situation. And then another thing, I think somebody had mentioned like non-infectious causes or like inflammation. So some of these are autoimmune things, like even the thyroid issues that Adam had mentioned. Lupus, systemic lupus erythematous can cause sort of like lumps in the neck or masses in the neck. Any sort of hypersensitivity to like a drug, like some sort of reaction as well. And then our first one that someone had mentioned was tumor as well. So we always got to think of malignancy, right? So it's a do not miss diagnosis. We definitely don't want to miss if this is something like cancer. And then developmental as well. But like I said, we're not going to really be talking about those causes. So good job. Keep those things in the back of your mind as we move through the rest of this case. Okay, so this is just a little chart about the differential diagnosis of neck masses in children. And then this picture here is just specifically about the lymph nodes and within the lymphatic system within the neck region. And this is really helpful because sometimes just based on like where our lymph nodes are enlarged, that can tell us a little bit about what might be going on, right? So you guys might have had these lymph nodes right here, the submental, submandibular. These might have been swollen in yourself before. I don't know. I feel like I can feel those be swollen even when I'm asymptomatic and not having symptoms. It just tells me that, hey, maybe I actually do have a little bit of a virus and my body is fighting it off. So this table here kind of shows you like where the lymph nodes are located and if they are swollen, what that might indicate. So let's just look at an example here. So let's see. So lymphoma or like a cancer or a cancer that has spread to the lymph system is basically if you have the supraclavicular lymph node, so under your like collarbones there, that's where your supraclavicular above the collarbones, that's where these lymph nodes lie. If those are enlarged, that might be very concerning, right? It's very concerning that they could have some sort of cancerous process going on. So familiarizing yourself with all of these different areas of lymph nodes and kind of where infections go, where cancers go, can be really helpful when you're doing your physical exam. On the quiz, you won't need to know, like, label these and anything like that, but this is just for your own knowledge and understanding. Okay, so when are we going to be concerned about a lymph node being cancerous? There are certain features about lymph nodes which might be more concerning that it's cancer versus something like an infection. So let's talk about these characteristics. If a patient presents and a lymph node is decreasing in size, do you guys think that is more concerning for cancer or less concerning for cancer? Less, right? Yeah, exactly. So we might have had some sort of reactive lymph node because of a infection or something, and now you're getting better, so it's going away. Whereas if you have a cancer that's being untreated, it has the potential to keep getting bigger. Okay, next one. Oops. What about a lymph node that is quote unquote matted or fixed? Matted is kind of just like fixed to the surrounding tissue and firm, and it's not mobile. You can't like move it around. More concerning for cancer or less concerning for cancer? More concerning. Yes, absolutely. So more concerning than if the node was mobile. If the node is able to be moved around very easily, that's more consistent with something just that's something that is reactive, either, inflammatory, infectious, that sort of thing. What about if somebody has this lymph node and they also have symptoms like weight loss, fever, night sweats? What do you guys think? Yes, definitely more concerning, very concerned, right? Yeah, those are some concerning symptoms that if we also have a lymph node that's enlarged, we're pretty worried about that. What if the node is painful and warm? Maybe an abscess, right? Yeah, so you might not be as concerned for something like cancer. In fact, nodes that are painful and warm versus painless and like more cold and just, normal temperature, those are painful and warm is associated with infection or like inflammation, not so much cancer. If it's painless, that's when we like our ears perk up and we're like, this could be something that something like malignancy. All right, what if you also have spleen enlargement, which is called splenomegaly? So this is one that's a little bit of guess what I'm thinking, because there are certain infections, like I don't know if you guys have heard of like mononucleosis. There are certain infections like that can cause enlargement of the spleen, specifically in mono. That's why patients that are diagnosed with mono are advised to avoid contact sports for a while, because if they play those sports, their spleen could possibly rupture. And obviously that's not a good idea. That's not a good thing. But there are certain cancers, especially blood cancers like leukemias, lymphomas, that can cause spleen enlargement as well. So if somebody's coming in with this lymph node and they also have like weight loss, fever, and enlarged spleen, then you're on high alert, because this is very concerning for something like malignancy. Okay. So as we just talked about, a lymph node is most often considered concerning when it possesses characteristics that suggest malignancy. So patients that are 2 to 12 years old, so younger patients, they often present with insignificant lymph nodes because they frequently have viral infections. And this is kind of what I was alluding to earlier when I said that sometimes, I can feel my neck and my lymph nodes under my chin feel enlarged, but I don't have any symptoms. And that's because it's just my body's doing what it needs to do, right? I might have a little bit of a bug and my body is adequately fighting it off. And so that's what happens when you're younger too. You get a lot of these, viruses and whatnot. And so you have these insignificant lymph nodes that are a little bit enlarged, but they're not concerning. And those would be, we would expect them to be mobile. We'd expect them to be a little bit painful, that sort of thing. And then ultimately decreasing in size. All right, so thinking about what we just talked about, what other things do you want to make sure to ask Noah and his mom about the concerning, or about the lymph node being enlarged, about the lump on the neck? I guess we haven't really established if it's the lymph node yet, but we think that could be what it is. What are some other questions to ask about it? And I can go back to real quick to the opening. Remember, he comes in with this lump. He's 15 years old. It's been here for about 5 weeks, and it might have grown in size. That's all we know so far. Okay. Let's see chat here. Yes. Have you been sick recently? Great. So we've just talked about, this infectious versus like malignancy type of thing with enlarged lymph nodes. So great question to ask is, have you had any sickness? Have you traveled? Yeah, that's also a great one as well. So have you picked up some sort of bug maybe when you've traveled or something like that, and you have an infection that way? That's another really important question to ask. Awesome. What else do you guys think? What have you ate recently? Okay, what are you getting at with that, Stephen? Anything else? Yeah, maybe a bad reaction from a food. Yeah, that's certainly possible. Some inflammation there because you had a reaction from something. Okay, let's see here. Oops. Somebody said family history such as thyroid disease. Yes, great, awesome. That was on our differential too, wasn't it? This like non-infectious, like a autoimmune or some sort of inflammatory thing of the thyroid. Great. Have they traveled recently? Yes. So another, good question that we had said. Awesome. Okay, so other things, yeah, how long has the node been enlarged? Is it enlarging rapidly or slowly? Sometimes the progression, is it going, the acceleration, is it enlarging very rapidly? That might be, an infection, or has it really slowly just like started to enlarge where you honestly don't really notice it, and then one day it's just there? Is it painful and tender? We had talked about the painful and tender nodes being more indicative of infection versus the painless being more indicative of something like cancer. Recent illnesses, as you guys had said, so any sort of symptoms that are associated with that, like sore throat, difficulty swallowing, which is called like dysphagia, fevers. Do they have any lymph nodes elsewhere, right? I think that's important too. Have they noticed any lumps or bumps elsewhere? And then asking about weight loss, muscle aches, fatigue, recent exposures, like we said, travel, maybe being around animals, which can cause certain bacterial infections, medications as well. Let me ask you guys this. So this is a 15-year-old boy. Is there anything else we want to ask him that could be causing his the lump or the bump or whatever we say, enlarged lymph node in his neck? Kind of talked about it earlier with when I was talking about the spleen being enlarged. Do you guys know any sort of infectious disease agent or infection, that can cause enlarged lymph nodes that would be common or maybe would be occurring in somebody that is of, the adolescent age? So the thing I was thinking about here was like mono, right? Mononucleosis. So it's sometimes called like the kissing disease because when it's typically teenagers and they can spread it through like kissing or other, sexual activity like that. And it can present with, a sore throat, and then it can present with enlarged lymph nodes as well. So it would be really important to ask him then, like, are you sexually active? Do you have a partner who has been sick recently? That sort of thing. And then drug use is always important as well. Some of those social history factors. All right, so let's read a little bit more about what is going on. I will just actually put up we'll just put up a few of these information, and then I'll let you guys read this right now. And then you can mention to me what you think is pertinent, what you think is not as important, that sort of thing. So I'll give you a minute or two to read these details. Okay. Anything in this part, the HPI, the review of systems, or the past medical history that stands out to you? Yes, doubled in size in a week, and it is fixed, right? So some characteristics that we're getting about the lymph node that might be more concerning to us. Lost a lot of weight. A couple of people said, weight loss, which is concerning, especially since this is a young boy who should be growing, right? Great. What was the original size again? They didn't actually give us what the size was. It was just increasing when we do the physical exam. I think I put the size in there. But you're just told right now that we know it's increasing in size. So we'll just say like it's probably a couple centimeters or something. So it's rather large. Okay. Night sweats, nausea, right? Yep. Great. So all of these are pretty, concerning symptoms. All right, so let's get a little bit more information. You guys read that. All right, what do you guys think about the rest of this information? Anything that sticks out to you? All right, so family history indicates his symptoms might not be due to a genetic condition. Great, right? Not a very remarkable family history. Just looks like his mom has had hypertension, father no chronic health conditions, etc. And then someone said, so Adam said, does have a girlfriend who he kisses, so mono could be possible, right? Yeah. So, but he has said that she's been healthy recently, so maybe that's lower on our differential, but yes, still certainly possible. So it was an important thing to ask him. Great. All right. Moving on. So, given all of this information that we've learned, what diagnoses from your guys' original differential list are now more or less likely? Are there any you want to add? Any you want to remove? What do you guys think? Let's start broadly. Do we think that, based on what we've learned, are we more concerned that this is a, malignant thing or a malignant process going on, or does this seem to be something like an infection? Yep. So it's fixed and it has grown fast, so likely cancerous, right? And you guys had noted too, he's having some nausea, night sweats, a lot of weight loss. So, right, yeah, we're a little bit more concerned about cancer. So, what parts of the physical exam do you want to focus on and why? We still need to do labs to rule out infection. Yeah, perfect. So, yeah, Stephen made a great point. When we do the workup, and I'll ask you guys a little bit about the labs you want to order or imaging, anything like that. We do, there are some certain lab tests that we can order, or certain throat cultures or tests that we can do just to rule out infection, right? Because we're not sure yet. We need to have tests to back up what we think and to prove to ourselves what is going on and to lead us to a different study or another direction that we need to go in to further narrow that differential. So great. I'm really glad that you brought that up. So yeah, we'll do some labs or in tests like that after the physical exam. But what parts of the physical exam do you guys think are important to focus on. Since he's got this lump in the neck. Yes, ear and throat. Great. Yes, ear and throat is a really great one to focus on when you have anything going on the neck, right? Head, ears, eyes, nose, throat. Great. Any sort of infection there, or even, cancer or process like that, need to make sure to check out all that area. We had talked about, excuse me, that this is probably an enlarged lymph node. So are there things that you want to do on the exam to further evaluate that? Check them all. Great. Yes, that was kind of a guess what I'm thinking question, but you got it. Wonderful. Yeah, we want to make sure that we look in all parts of the lymphatic system, right? Because if this is a cancer, as you guys have said, and it's gotten into the lymphatic system, has it spread anywhere else, right? That might tell us, more about the staging and the prognosis. If this is a cancer, if it's spread, that's really not a good sign. So we need to be very diligent about checking all of those areas of the lymph node, especially in the head and the neck region, since that's where this big lump is. Okay, great. So this is the physical exam. I'll let you guys take a look at this for a second here. Kind of read through it. All right, so let's talk a little bit about what are some of the abnormal things you guys have noted. So yes, enlarged lymph nodes in the supraclavicular regions. Yes, very, very, very concerning for cancer, which you guys might know from maybe any studies that you have done, but also from what I mentioned earlier in this this lecture, this case here, was that supraclavicular region right above the clavicles, you can have them kind of bend forward, and so you can get a little bit of like a divot in that area and really dig your fingers in there and feel for the lymph nodes. But when you have an enlarged lymph node in that area, it's very concerning. Right. Anything else that we notice? Pertinent negatives as well, things that are negative. Do you guys understand what I'm sorry, positive and negative means? Like positive, so for example, he has enlarged lymph nodes in the supraclavicular regions. That's the presence of something that's concerning. Negatives are, the absence of concerning things. So for example, this guy does not have an enlarged spleen. So, that's probably a little bit more of a good sign, right? That's normal to not have an enlarged spleen. So we had earlier said, yep, there we go. Great. Awesome. So yeah, negative for any irregular vitals. He doesn't have any murmurs, regular heart rate. He's got equal pupils. Awesome. Looks like his thyroid feels normal. We had said earlier that maybe thyroid issues would be on the differential too. So yeah, all good things to note. Great. All right, so now let's talk about what sort of labs, imaging, or other studies might be important to continue on our workup or start our workup for this patient. Let's see, would you do an MRI or a blood test? Yeah, so any sort of imaging I think would work. I think starting with an MRI, MRIs are very expensive, right? So we might want to start with something like a CT of the neck, or even just a basic chest X-ray to see if there's any enlargement along the mediastinum, which is like the area within like around the lungs in your chest cavity. Sometimes the lymph nodes, if they're enlarged in that region, that can be pretty indicative of certain types of cancers. But we can eventually go to an MRI if we don't see things on, studies like CT or chest X-ray. So yeah, probably a CT. Blood tests, great, any blood tests, because when we look for the CBC or the complete blood test, if the white blood cells are elevated, that can be indicative of certain blood cancers, but it could also be indicative of an infection too. So all good things. So basic labs, probably CT. What about the lymph node itself? Is there anything you want to do, since we know it's like enlarged, fixed? We're pretty concerned that it's cancer. Is there anything that you might do to further evaluate what's going on in that lymph node besides the CT? Yeah, biopsy. Yeah, a biopsy. So taking a sample of that lymph node, or which I guess I'll talk about in the slide to come, but an excisional biopsy. So removing that entire lymph node versus just doing what's called an incisional biopsy and like taking a little piece of it. Just taking all of it is probably more important because you get a better yield, because there's a possibility that if you just take a sample, you're going to miss the part that has something concerning in it. So yeah, definitely, I think it's totally reasonable to do a biopsy at this point. So let's just talk about some of these things. And you guys have already mentioned some of them, but so even in a well-appearing child, and this guy does appear well, but we know he's been having weight loss and night sweats, but it's appropriate to order some lab and imaging studies if the elements of the history and exam are concerning. So we had mentioned just basic blood levels, so a CBC, a complete blood count, looking at his electrolytes, his liver function, his kidney function. We can look at something called serum lactate dehydrogenase. So lactate dehydrogenase is an enzyme in our body, and when it is elevated in the blood, that suggests that there is some sort of tissue damage going on for some reason, and is often elevated in cancers. Specifically, like lymphoma often has an elevated lactate dehydrogenase. We can do some inflammatory markers. And then, as someone had mentioned earlier, we can do certain tests to rule out infection, just to be sure. If we're concerned about mono, we could do something like the EBV or monospot. Epstein-Barr virus is what causes mono. You can do a little test to check for mono. If we were concerned about strep throat, you could just take a little throat swab. So those are all things to consider when working up this patient. And then for our imaging options, chest X-ray. So chest X-ray and a CT scan can help determine the extent of the disease if this is cancer, and it can also help us guide the biopsy of the neck mass. We could even, ultrasound the lymph node too to look at it, and that can give us some sort of more characteristics into the features of the lymph nodes, and if this is like infectious versus if this is malignant. And then, as you guys had pointed out, an excisional biopsy is probably a good idea because we're pretty concerned about this guy. He's just matted and fixed. It's painless, all things like that. So just taking a biopsy of it from the get-go is probably a good idea. This says here, so the way that we do this, choose to do a biopsy or not in clinical practice, is you often just look at the size, and then you also ask yourself, has this gone away? Is it getting bigger? Do they also have concerning symptoms? The answer is yes to all of that, and it's rather large. You might want to just start with a biopsy right away. Great. So what do you guys think about for our patient? Should we do labs, CT, and biopsy? I think we've already kind of established that. So I agree with you guys. Great job. Okay. So here are the results. And highlighting some pertinent things. So any comments on some of the results? What do you guys think as far as what's boxed in there? So that LDH there is that lactate dehydrogenase, it's elevated. So this might suggest that we're having some tissue damage. What do you guys think about the white blood cells being elevated? Infection, yeah, infection versus like a cancer. So there are different cells, blood cells in our body, which we'll talk about. There's the white blood cells and the red blood cells, and the white blood cells are those that fight infection. But we have things like lymphocytes, and we have things like neutrophils, that sort of thing. And if you have an elevation in white blood cells, that can be concerning for yes, in infections, your body is producing more of them to fight it off, or you have some sort of clonal expansion of those cells because of cancer. So that's something to note here. His platelets being elevated. Platelets are kind of an inflammatory marker in some cases. And so this can be suggestive of just like some inflammation maybe that's going on. We'd already talked about LDH. So the chest X-ray doesn't have any enlargement of the mediastinum in that chest cavity. And so we're less concerned probably that there are some lymph node enlargement in that area. So that's actually probably a good sign. And then, of course, we did the CT of the neck, as well as like we looked at the rest of the body. And this just shows some lymph nodes in the right side of the neck and the supraclavicular region. So that lymph node that we felt on exam is shown on CT as well. So you guys had picked up on that. And so that was good. So what are your comments on the results so far? What do you guys think? Are we pretty concerned that when we biopsy this, it's going to be cancer? Yes, yeah, we are pretty concerned. Exactly. Okay. Um, and so let's see. So we had wanted to perform an excisional biopsy, and I wanted to make note here too of what I had mentioned earlier, and you can do an incisional or like just taking samples of the lymph node, but an excisional, taking the entire thing, is preferred because then you get a better yield of the sample and less error for like missing what could possibly be going on. Okay, so here's your biopsy results. So this is not going to, these words might not make sense to you now, but we'll talk a little bit about the pathology of this, okay? But the biopsy that we did revealed these large B cells. So we have B cells and T cells, which we'll talk about. They're both part of the immune system. So these large B cells here have multi-lobed nuclei. So they have two nuclei, which is not normal. We normally just have like one nucleus in our cell. And prominent nucleoli. These little guys, these cells are known as Reed-Sternberg cells, and they are hallmark for lymphoma, specifically for Hodgkin's lymphoma. So anytime you see these guys with the two multi-lobed nuclei, they just kind of look kind of funky, kind of look like eyes, honestly, like two like fried eggs or two like eyes there. That's concerning for Hodgkin's lymphoma. And specifically, there's different subtypes of Hodgkin's lymphoma, but the one that has a bunch of like sclerosis and fibrosis and around these like nodules is known as the nodular sclerosis subtype. And there are special stains that we can do to tell us what kind of cells these are. So these cells, these specific ones known as Reed-Sternberg cells, the hallmark for Hodgkin's lymphoma, they stain positive for something called CD15 and CD30. And those are just specific markers found on the cell, okay? So anytime you have something that looks like this, stains positive for the CD15 and CD30, you are concerned about Hodgkin's lymphoma, okay? So we have diagnosed this boy with Hodgkin's lymphoma. So let's talk a bit about the pathology, because this is, the important parts of these sessions are learning from our cases. So what is Hodgkin's lymphoma? We've already talked about the lymphatic system being carrying our cells of the immune system to the areas of our body that need to fight infection. So Hodgkin lymphoma is a type of cancer that develops within that lymphatic system. Specifically, it's a cancer of lymphocytes. So when we think of blood cells, and this is a really nice diagram, I think over here, when we make our blood cells of our body, we start in the bone marrow with this stem cell. And the stem cell can become any type of blood cell, okay? But it chooses to go down different pathways. One pathway it can go down is called the myeloid pathway. And the myeloid pathway eventually makes things like red blood cells, platelets, neutrophils, things like that, okay? And when we have expansion, so like cancerous expansion of some of these cells, some of these precursors of this myeloid pathway, that gives us our leukemias, okay? Our blood cancers that are called leukemias. However, we can also take the stem cell and go down this pathway. This pathway is known as the lymphoid pathway. And the lymphoid pathway eventually becomes our lymphocytes, our B lymphocytes and our T lymphocytes. These are our main guys as far as our cells, as it goes for our cells that fight infection. Our T lymphocytes specifically are important for fighting viral infections, and our B lymphocytes are really important for making antibodies, which go on, and then next time you have an infection, those antibodies will help you fight it off, okay? So they are really important for fighting infection. And so when we have expansion of these lymphocytes, so like a bunch of the lymphocytes, and they just multiply and multiply and multiply, that's known as a lymphoma. So again, from this myeloid side, when we have a bunch of them multiplying, that's sort of like those are the leukemias, and they mostly stay in the blood. Whereas when the lymphomas, when the lymphocytes multiply by cancer, they become a lymphoma, and they often become solid masses, like within the lymphatic system. Okay. And so this just is kind of what I already explained. So the lymphomas arise from this lymphoid pathway here, and the leukemias, which we didn't talk about today in today's session, but I just wanted to be to let you guys know that and be complete with this, and that they come from the myeloid pathway. Okay, so let's talk a little bit more about this Hodgkin's lymphoma and the Reed-Sternberg cells. So there are two general types of lymphomas. So you can have a non-Hodgkin lymphoma and a Hodgkin lymphoma. How do we know the difference? The Hodgkin lymphoma is going to be the one that has these Reed-Sternberg cells that we saw on the adolescent boys biopsy, okay? That's the Hodgkin lymphoma. Non-Hodgkins are not going to have these cells, okay? So anytime you see this, you're concerned for Hodgkin lymphoma. So most Hodgkin lymphomas are referred to as this classic type, and there are 4 different subtypes. Our patient has this nodular sclerosing subtype, but we have a few other subtypes as well. And as we had mentioned, these Reed-Sternberg cells, they have these multi-lobed nuclei. They're also known as Hodgkin cells, and they stain positive for CD15 and CD30. I want you to know this for your quiz. So when you see these Reed-Sternberg cells, they stain positive for CD15 and CD30. Okay. So the epidemiology of Hodgkin lymphoma. So it only accounts for about 7% of childhood cancers. However, it's the most common childhood cancer in this adolescent age group, okay? It follows what's called a bimodal distribution. So that means it has a peak in young adulthood, then it kind of goes back down for a while, and then it peaks again when you get to be adults greater than 55 years of age. So it's common more in those like adolescent, young adulthood patients, as well as those that are of, older than 55 years of age. There are different risk factors for Hodgkin lymphomas, some of those being immunodeficiency disorders, if you've had transplants before, if you have even a mono-infection or infection with Epstein-Barr virus, which can lead to mono, that can make you at risk for Hodgkin's lymphoma. And what do the patients look like when they come in? What sort of symptoms do they have? So similar to our patient, he had the weight loss, the night sweats. Those are known as what we call quote unquote B symptoms. So B symptoms are things like fever for unknown reason, lots of weight loss for an unknown reason, so more than 10% of the body weight over 6 months, and a lot of night sweats, so drenching night sweats. So these symptoms are very important for staging because if you have these symptoms and you have lymphoma, you might be a higher stage than if you have lymphoma without these symptoms, okay? Other symptoms that, can come with lymphoma are swollen lymph nodes in other areas, itchy skin, fatigue, etc. And you can also have lymphoma. So why do we do the chest X-ray? We are looking for that mediastinal masses or that enlargement of this area right here around the heart and around the lungs. So as you can see here, this is pretty enlarged. It's atypical. And so that's concerning that this person has like cancer that is spread to this area. We can also have the tumor. So when the tumor has spread to the mediastinum here, you can see this picture here, the tumor. If you have a cancer that's spread to that area, it can block this venous drainage. And when you block that drainage, that can cause something called SVC syndrome. It's blocking the superior vena cava of the venous system, and it causes this buildup, swelling essentially, and fullness of the face, swelling of the arm, chest pain, cough. These patients have very difficulty breathing. That's an emergency, okay? But our patient didn't have that. And when we did the chest X-ray, it was normal. All right, so how do we stage and treat Hodgkin lymphoma? So does anybody know what stage is when we refer to like the stage of cancer? So our staging is how like large the tumor is and how much it has spread, okay? And it can give us a lot of information about like how to guide treatment and about prognosis, that sort of thing. And so in order to accurately stage, we have to do studies that, will evaluate for has this spread, right? We've already done one with this patient. We've done the CT scan, but there's a special imaging study called the PET, so the positive emission tomography or the PET CT scan. And this guy is really helpful in, telling us, has this cancer metastasized, AKA has it spread to other areas? And this is really fancy. So the way that it works is the patient will receive a radioactive tracer that is essentially hooked to a form of glucose with like radioactive material. And so what this does is the cells that are very active and using a lot of glucose will take up that tracer and then emit some of that light. And so when you look at this on the screen, then you can see how like cancer cells, because they're very active, they're going to be using a lot of glucose, they will light up. And so you're able to see that if the cancer has spread to other areas. Okay, super fancy, pretty cool. Lots of interesting physics that I have not learned and probably would not understand. But it's a very useful thing as far as cancer staging goes. And so let's just talk about a simplified version of how we stage Hodgkin lymphoma, okay? For time's sake, we're not going to talk about the A, B, E, and S categories. It's just a little bit of extra, but I just want to go over the simplified version here because there's a question on your quiz about the staging. And so for stage 1, that's when you have lymphoma that's localized to just a single lymph node, okay? Single lymph node in one area, that's stage 1. When it's in two areas, so for example, like up here in the neck and then maybe in the armpit, that's stage 2. So in two areas, but it's still above or below the diaphragm and on the same side of the body. So we can see on this person on their right, they have a lymph node in the neck and then in the axilla that has disease in it. So this would be stage 2. Now, stage 3 is 2 or more lymph node regions, and they're above and below the diaphragm or on opposite sides of the body too. So this guy, now it's stage 3 because instead of being in the armpit, in the axilla, it's down here near the groin. And then stage 4 is when it goes on and it involves like other organs. Okay. And then, so when we think about treatment for Hodgkin lymphoma, based on the staging and whether or not they have those B symptoms, we put them in risk groups. So low risk is somebody that has stage 1 or stage 2 without symptoms. So I don't have any weight loss, don't have any night sweats, that sort of thing. That's low risk. Intermediate risk is stage 1 or stage 2. Or the B symptoms, like with the B symptoms. So stage 1 or stage 2, and I am having weight loss. I am having night sweats. And then high risk is stage 3 or stage 4 with the B symptoms, okay? And then for high risk, especially, you're going to get both chemotherapy and radiation. For low risk, you may or may not have radiation therapy. And for intermediate risk, you often have just like a low dose radiation and or like high dose or low dose chemotherapy. So let's go back to our case. So he returns to clinic with his mother a week after the biopsy to discuss the results. He's also had a PET scan in the interim, and it showed uptake in the lymph node areas, but didn't show it like anywhere else. So it has not metastasized. So he's got uptake in the lymph node of the neck as well as the supraclavicular region. So what stage do you think he is at? So we know his lymph nodes are enlarged in the neck and in the supraclavicular region. What do you guys think as far as stage? Stage 2, yeah, great job, guys. Because that can be pretty difficult to remember. But yeah, stage 2, right? So he's got 2 or more lymph node regions on the same side. So neck here, and then his supraclavicular region. So he is stage 2. Okay, and we didn't talk about the the B, E, S, and A, but you don't need to know that. That's fine, just for time's sake. So for him, he's intermediate risk. And he's intermediate risk because he's stage 2, but because he also has those B symptoms, right? He has those night sweats, weight loss, that sort of thing. So do you guys think he will need both chemotherapy and radiation since he's intermediate? Yes. Yeah, he'll likely need both of them. So let's talk a little bit about how we treat Hodgkin's lymphoma. So specifically for chemo, let's talk about chemotherapy. So chemotherapy, there are many treatment regimens that include a lot of different drugs, but we'll talk about one that's one of the most common for Hodgkin lymphoma. Oh, you're welcome. Yeah, if you guys need to head out, that is totally fine. We're going to run a couple of minutes over, probably a few minutes over 9. But thanks for coming if you do need to run out right at 9. And I'm sorry, that's 9 o'clock my time, Central Time, but I'm not sure what time it is at where you guys are at, but the class is supposed to end in like a minute or 2, but I'll go over just to finish the case. But feel free to if you need to leave. Okay, so one of the earliest chemotherapy regimens is known as the ABVD regimen. It's an acronym for these drugs called adriamycin, bleomycin, vinblastine, and dacarbazine. You don't need to know the names. I just kind of wanted to give you an example of one of the most common ways that they treat Hodgkin lymphoma. And there's a bunch of different regimens with different drugs nowadays. So when you do chemotherapy, each cycle lasts 4 weeks, so 28 days. You'll get chemo on day 1 and on day 15, and then you rest, in between. And then each cycle, again, is 28 days, and the patients will usually have between 2 to 8 cycles. And you'll often get like imaging, after a few cycles to see like how things are going, how your body is reacting to it, if the cancer is, being killed off, that sort of thing. Typically, all of the drugs are given by an infusion. The total time is usually about 3 hours. It can be given in an outpatient setting unless the patient's not doing very well, then they might have to come to the hospital to get the infusions. So this is just a picture of those drugs. So his chemotherapy plan, we have decided that he's going to have this ABVD chemotherapy. And then we're going to check him with a PET scan to determine, how well the chemotherapy worked. And then he will likely have radiation as well to where the disease started. So up in his neck region with his supraclavicular nodes and his neck nodes. So are there any labs that you guys think should be monitored while he undergoes chemotherapy? What do you guys know about chemotherapy drugs? They're really good for curing, for like killing cancer. But what about the healthy cells in our body? How do they affect those? Blood test. Yes. Yeah. So he will likely need to follow, we'll need to follow his labs for sure. So chemotherapy agents, so the reason they work so well, right, is because they're very good at killing cells. They often, the mechanism of action is various, but, some of them interfere with like microtubule function in cells. Some of them interfere with like DNA replication, so on and so forth. So you can imagine though, that this means that there's lots of side effects too, because our healthy cells might, be damaged as well from the chemotherapy, especially cells that are overturning a lot. So like hair cells, skin cells, that's why you have a lot of those side effects. So Stephen has said, make sure it's targeting the cells we want and not the good cells. Right, yeah, so more like modernized drugs are better at targeting specifically the cancer cells, but still most chemotherapy agents will cause some sort of, side effects because they just are very potent, and we can't always just target directly the cancer cells, although we do try. Okay, so also I wanted to mention too that specifically this bleomycin drug, bleomycin, can cause a restrictive lung disease. So patients will also often undergo pulmonary function tests before they treat with bleomycin, just to make sure that the lungs are healthy enough to have this treatment. So here's some common reported side effects of this chemotherapy regimen that our patient's going to be on. So hair loss, nausea, vomiting, anemia. So again, why we need to monitor those labs, increased bleeding risk, low because of the low platelet count. Again, that's why we're monitoring his labs, that sort of thing. But in general, for this specific regimen, it's rare for patients to have to stop it due to the intolerable side effects. Most patients, almost all of them, are going to receive all planned cycles for treatment. So that's good. So how the case ends is Noah ends up doing well with chemo and radiation. Around 90% of people will survive their Hodgkin lymphoma diagnosis for 5 or more years after. So he is going to continue to follow with an oncologist or a cancer doctor, and he goes on to live a happy, healthy life. All right. So you guys are free to do the quiz. Thank you for participating. I hope you learned something this session. You guys had wonderful thoughts as always. Are there any questions before we sign off? Okay, well, if not, yeah, like I said, I just want to thank you guys again for coming and for participating and really thinking critically about this, and hopefully you learned something.